Hello, everyone. Today, we are exploring vasculitis, an important, often complex group of diseases where inflammation targets the blood vessels themselves. This inflammation damages vessel walls, causing them to narrow, thicken, or even rupture. The outcome is reduced blood supply, tissue ischemia, and sometimes organ failure. Remember, blood vessels nourish every organ. So when they're inflamed, almost any organ can be at risk, from the brain and eyes to the kidneys and lungs. Vasculitis is not a single disease. It's a family of conditions that share one mechanism, vessel wall inflammation, but differ in cause, vessel size, and clinical pattern. Clinically, we classify vasculitis according to the size of the blood vessels involved, large, medium, or small. Large vessel vasculitis involves the aorta and its major branches. Classic examples are giant cell arteritis and Takayasu arteritis. Medium vessel vasculitis affects main visceral arteries and their branches. The prototype is polyarteritis nodosa, where inflammation leads to aneurysms or infarcts in organs such as the kidney and intestine. Small vessel vasculitis affects arterioles, capillaries, and venules. It includes ANCA-associated vasculitis, immune complex vasculitis, and cryoglobulonemic vasculitis. Why does this size-based classification matter? Because vessel size predicts which organs are affected and helps us choose the right investigations. Pathogenesis. The root cause of vasculitis is usually an abnormal immune response, but the mechanisms differ between types. In ANCA-associated vasculitis, autoantibodies called ANCA activate neutrophils, which release enzymes and oxygen radicals that injure vessel walls. In immune complex vasculitis, circulating antigen-antibody complexes deposit in vessel walls, attracting complement and inflammation. In granulomatous vasculitis, like giant cell or Takayasu, T cells and macrophages form granulomas that destroy the vessel wall. Some vasculitides arise secondary to infections, drugs, or autoimmune connective tissue diseases like lupus. Clinical features. The presentation varies widely, but every patient shows a pattern based on which vessels and organs are involved. Common systemic symptoms include fever, weight loss, fatigue, and night sweats, the body's inflammatory response to vessel injury. On the skin, small vessel vasculitis causes palpable purpura, small red or purple raised spots that don't blanch. Medium vessel involvement may produce livedo reticularis, a net-like pattern, or painful nodules on the legs. When nerves are affected, patients develop mononeuritis multiplex, asymmetric weakness or numbness due to ischemia of peripheral nerves. Kidney involvement produces blood in urine, proteinuria, and rising creatinine, a sign of glomerulonephritis. Pulmonary involvement leads to cough, breathlessness, and sometimes hemoptysis from pulmonary capillaritis. In large vessel vasculitis, like giant cell arteritis, the key clues are new headache, scalp tenderness, jaw pain while chewing, and blurred vision, all warning signs of possible blindness. In Takayasu arteritis, usually in younger women, we see absent pulses, unequal blood pressures between arms, and limb claudication. Diagnosis. Diagnosis begins with basic labs, ESR, CRP, blood count, and urinalysis. High inflammatory markers suggest systemic inflammation. Next, specific serologies, ANCA testing for small vessel disease, complement levels, and cryoglobulins if immune complex vasculitis is suspected. Whenever possible, a biopsy confirms the diagnosis. For example, temporal artery biopsy in giant cell arteritis, or kidney biopsy in ANCA disease. Imaging such as CT angiography, MR angiography, or PET scan helps identify vessel inflammation, stenosis, or aneurysm in medium and large vessels. Each of these steps narrows the diagnosis and rules out mimics like atherosclerosis, infection, or embolic disease. Treatment. The first goal is to control inflammation rapidly and prevent irreversible organ damage. High-dose corticosteroids remain the mainstay. In giant cell arteritis, steroids must be started immediately if vision symptoms are present. For severe or ANCA-associated vasculitis, we use cyclophosphamide or rituximab to induce remission, followed by azathioprine or methotrexate for maintenance. For eosinophilic granulomatosis with polyangiitis, mepolizumab targets interleukin-5 to reduce eosinophilic inflammation. Supportive care includes blood pressure control, infection prophylaxis, and monitoring for steroid complications. Examples. Example 1. Giant cell arteritis. A 72-year-old woman presents with new temporal headache and blurred vision. Prompt steroid therapy saves her sight. Example 2. Granulomatosis with polyangiitis. A middle-aged man has chronic sinusitis, cough with blood, and rising creatinine. Positive PR3 ANCA and kidney biopsy confirm the diagnosis. Both examples show how vessel inflammation, if recognized early, can be reversed before organ loss occurs. Complications and prognosis. Untreated vasculitis can cause irreversible damage, blindness, renal failure, aneurysm, or stroke. But with modern immunotherapy, remission is possible in most patients, though long-term monitoring is essential to detect relapses. Key takeaways. First, think by vessel size and pattern of organ involvement. Second, confirm with biopsy or imaging whenever possible. Third, treat giant cell arteritis urgently if vision is threatened. And fourth, maintain remission with the least immunosuppression needed, balancing benefit and toxicity. Vasculitis is therefore not just an inflammation of vessels. It's a systemic warning that the immune system has turned its weapons inward. Early recognition, thoughtful classification, and prompt therapy can truly save lives and organs. Thank you for listening.